Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended with single-sided deafness, this in their left ear. Now, I actually performed the procedure in the right ear first, but for the purposes of this video, I've decided to show the left ear first. Hence why you can see the suction probe just to the left has got some wax adhered to it. So that's from the patient's original right ear. Now, with the instruments, as long as the patient hasn't got an active ear infection, we can use them in both ears. But of course, we do not use them between patients. So these instruments are all single use because they're obviously medical devices, and so they're disposed of in a sharps bin post procedure to avoid any cross contamination. Now, single-sided deafness. So this patient was diagnosed with an acoustic neuroma. I think back in 2011, and I'll come back to the moment. So you can see I began using a Zollner suction probe, performing microsuction. The surface of the wax, in particular, was quite firm. It wasn't going to suction unless I put some drops in, and there was an opportunity for me to use a hook. There's an opening at the top. You can see I'm just using a St. Bart's heel hook just to slowly extract this wax out of the ear. Now, if you continue to watch till the end of the video, you will see just how big the wax hook is, because I think when you watch a video, it looks a lot larger than it is in reality. And I've put it against the wax, and I've put it against the tip of a pencil, like I sometimes do, and you'll have to gauge the comparison. So I'm just slowly using the hook to extract this. So acoustic neuroma is also known as a vestibular schwannoma, and it's a benign tumour, so it's non-cancerous, and it actually develops on the balance nerve. Now, the eighth nerve is called the audiovestibular nerve, and it's intertwined with both the balance and hearing nerve. And on the balance portion of the vestibular auditory nerve, it's called many different names. I forgot what I said it was at the beginning of the video, or a moment ago, sorry. But it's just the auditory nerve, so it's the hearing nerve and the vestibular nerve. So vestibular cochlear nerve, that's another name given to it. In any case, this benign tumour, so soft tissue growth, it develops on the balance aspect of this eighth cranial nerve, and so therefore one of the main symptoms of an acoustic neuroma is vertigo, so balance problems. You can see just removed a big large chunk there. I'll come back to that moment. Now, this patient in this ear, the patient's literally got no hearing, so I'm not too concerned about any clarinetting with such things. Can't hear it anyway, but I just want to get this skin off as much as I can, as safely as possible. And that's because they do suffer from a lot of itchiness and irritation. You can see this dead skin now. Whilst I was removing this, the patient was talking a little bit. So it's a bit, when you talk, what happens with jaw moves, and I think it was just momentarily or on a few occasions. So I just had to be really careful. And I did ask the patient just for the moment, just to pause, just so we could remove this. So the primary symptom was vertigo. They went to and also hearing loss, and they also developed tinnitus in that ear. But what really made them aware of the main major issues of the vertigo. So they saw their doctor, referred to ENT, had an audiogram, so hearing test performed, and detected an asymmetric hearing loss in the left ear. Well, the left ear is completely almost dead, there's no hearing there, and vertigo and tinnitus. So we call that a red flag symptom. So if you've got tinnitus worse or only in one ear, and it's there more often than not, and if you've got significant hearing loss in one ear compared to the other, we call that a red flag symptom, and it just means in the UK at least they undergo an MRI scan just to make sure they don't have this acoustic neuroma. This patient went for the scan and they were diagnosed with an acoustic neuroma, and for the first couple of years they were just monitoring the size of this acoustic neuroma, because I believe only 10% of these acoustic neuromas actually then decide to grow and get bigger, and if they do, obviously something needs to be done, because it's the tumour's below the brain, and obviously we don't want it to get too big where it compresses against the brain and cause other damage. So for the first couple of years, the tumour wasn't really growing, but the third scan, they found that the tumour did grow quite significantly, whereby it was decided to act, and what they underwent, the patient, was gamma knife surgery. So they had targeted gamma knife surgery where they're not removing the tumour, but they're trying to shrink it and stop it from growing. And they did that for 5 years, I believe. And then when they went the subsequent year, they were told that actually it's not growing anymore. And I think the 7th year, they were told that it's slightly shrunk. So the patient's now been discharged, and they don't need to go back for any further scans anymore. So that was, in that sense, it was good news. But it has left the patient with single-sided deafness now. They have got very, very minimal hearing in this ear, but it's not enough to process the sound or recognise what's being said. So they're solely reliant upon their right ear. The patient was advising that they developed their acoustic neuroma whilst being a school teacher, and they found it really, really difficult because it's an open plan room and you've got children all around you. She did continue to work, but she'd really, really struggled at times, and she did try what we call a cross hearing aid. So a cross hearing aid, the abbreviation acronym is CROS, and it stands for contralateral routing of signals. And essentially, what this patient had, they had more or less normal hearing in the other ear, the right ear. So they had a hearing aid in the right ear, but the hearing aid in the right ear wasn't amplifying any sound, so it wasn't increasing the volume of sound because they didn't need it in the right ear, it was normal. But they also wore kind of a transmitter. It looks like a hearing aid in the left ear. So with the transmitting hearing aid on the left side, the hearing aid microphones picked up the sounds arriving from the patient's left-hand side and wirelessly transferred that signal, that sound, into the hearing aid in the right ear. And then the hearing aid in the right ear played that sound into their right ear. But without increasing the volumes, their right ear was normal. So essentially, the patient was able to hear sounds coming from the left side in their right ear. And it helped in certain situations. So when they were in the car driving in the UK, drivers on the right hand side and the passengers to the left. So she was able to hear the passengers from the left hand side. But other than that, she found it a bit. It actually made matters worse. It just confused her because everything was just coming from the right, and she wasn't. It actually just threw her off balance a bit. It just threw her off where her awareness, her spatial awareness. So she decided not to continue to wear the cross system, and she just continued to manage, and she's doing quite well now. She's no longer working, she's retired, but she's managing quite well, other than this, well, it's actually dead skin, it's not earwax, and that was the case on both sides. She has otitis externa, she's got medication for it, both ointments for she's also got eczema and otitis externa of the outer part of the ear, what we call the pinna, so the satellite dish that you can see on the outside part of the ear, and also some sprays for inside the ear. Now, the right ear, the reason why I showed it to you last was this is the more complex ear, it always is, and it's because the entrance of the ear canal's collapsed. You can see how it's a bit inflamed, it's spongy, and at the beginning of the procedure, it was a bit difficult. I have to, after a few attempts, I kind of got the rhythm of the ear, I got this feeling of the ear, but I'm having to really, really stretch this ear open, and if I didn't, I wasn't able to insert the instrument in, but also, if I wasn't stretch the ear wide enough, the entrance of the ear canal was collapsing upon itself. So it's almost like a black hole. I was trying to figure out how to explain that, but the suction probe, as it was entering the entrance, because it was so narrow, because it's inflamed, the suction probe was actually sucking in the canal. So the canal wall is getting sucked in, and I just thought about it like a black hole. It was almost like a black hole effect. The sucker was trying to collapse the canal into the sucker. So I had to really, really stretch this ear canal wide open so we're not causing that black hole effect, if you like. And I'm having to use the endoscope to do that. So the tip of the endoscope is being held in my left hand. I'm going just into the entrance and I'm pushing the cartilage to the left. And then that not only straightens and widens the ear canal, but it allows enough space for me to insert the instrument. And as I'm bringing this wax out, even though I'm stretching the ear is still quite narrow, and this plug of wax and skin is larger than the entrance. So then it's a bit of a wriggle and a bit of a tussle to get it through. But we did manage in the end. Now, because this is their only hearing ear, we just have to be a bit more cautious. So there was a bit of skin in the end, and again, the patient just, as I said, suffered from itchiness and irritation. So I removed a bit of skin, but then it was a hint of clarinetting, and I just stopped immediately. We don't want to make any, we don't want to be silly in this ear, especially because it's the only hearing ear. So as soon as there's a hint of clarineting, we just stopped immediately. But the patient could hear very, very well. So again, just got to stretch this ear open. You can see it's a bit more mushier here. I couldn't use a hook in this side because it was a bit more mushy. The hook will just dissect it. Almost like a soft butter consistency. Or Jobson horn, it's really weird. I'm still using Jobson horns, of course, but I think with any specialist and anything they do, I think you go through phases where actually you kind of fall out of favour with a particular instrument for whatever reason. I'm just thinking back, and last time I really used a Jobson horn, and kind of feel like I've managed to. I think with a Jobson horn, sometimes the surface area is a bit wider, and so with a hook, I prefer it sometimes because the profiles are narrower, and we can get into smaller spaces. And I'm trying to think. I must have a few videos with the Jobson horns. I'm still ordering them. I must be using them still for that reason. So you can see there's a little piece of almost like a blister on the eardrum there, and that's. You'll see that in a moment, just to the right centre. You can see how bendy this ear canal is as well. So you can see there's a bit of dead skin around the edge. Just going to remove this. Yeah, I think with the Jobson horn, I'm finding that sometimes it's when you're removing the wax and it's a bit softer, it's almost compressing it against the canal wall. So you're getting a bit out, but it's also smearing a lot of it out. And I think in cases where I've previously used the Jobson horn, I'm actually managing to remove the wax or dissect the wax with an ear hook, then I can go back in with a sucker to remove. So I'm just removing this. Now we've got to be careful here. Don't want to touch the canal wall in any way, and just lifting this up. And at the moment there's no clarineting, which is good. I think just in the moment there's just a hint. Immediately we're just going to leave the rest of it in. It's not imperative to remove everything out. The patient can hear. You can see we've got the majority out anyway. So we're getting closer to the eardrum now. I think it's around now, if I remember correctly. There was a bit of clarineting this part. And you can actually see the skin moving even when the sucker was at a distance, it was flapping even though the sucker wasn't near it, and that can cause clarineting. So that's all the debris from both ears. You can see the big lump in the middle from the left ear, which I managed to remove the hook. So the hook, you can see there, it always looks big in for me. Now I'm looking at it in this view. It looks bigger in the ear, but you can see it's quite narrow. Well, I hope you enjoyed that video, guys. Take care of yourselves, and remember, be nice and be kind. Thank you, bye.